Endoscopic spine surgery is becoming the standard of care for degenerative disease of the lumbar spine. With increasing indications of endoscopic spine surgery, surgeons have reported its application not only for paramedian disc herniations, but also for central disc herniations, highly migrated disc herniations, sequestrated disc herniations, thoracic and cervical disc herniations, and more recently, the lumbar canal stenosis. Hence, it is essential for the endoscopic spine surgeons to be aware of the potential hazards and unexpected complications of the procedure so that appropriate care is taken to avoid adverse event as much as possible. The purpose of this review was to summarize the reported complications of transforaminal endoscopic discectomy for lumbar disc herniations. These were the complications of endoscopic spine surgery, which were divided into intraoperative and postoperative. Intraoperative again was subdivided into local and systemic. The local complications, what we can expect is injury to the neural structures, dural tears, injury to vascular structures, injury to peritoneal contents, the missed fragment, injury to the pedicle, instrument-related complications, and wrong level surgery. And the systemic complications can be seizures or posterior neck pain. In postoperative period, the immediate complications can be postoperative dysesthesia, residual pain, de novo disc prolapse, neurodeficit, epidural hematoma, retroperitoneal hematoma, and dyspnea and deep vein thrombosis. And the delayed complications can be postoperative spondylodiscitis, psoas abscess, post-discectomy pseudocyst formation, recurrence, instability, epidural scarring and fibrosis, and chronic axial back pain. The injury to the neural structures and dural tear. The first step to avoid this complication would be the placement of the needle. That is cautiously to be done under CM guidance. The tip of the needle should target the lower half of the foramen and should lie at the posterior vertebral margin on reaching the midpoint of the pedicle. The dural tear of the thecal sac and the nerve root can occur during this procedure. The tear may be caused by an endoscopic forceps or a laser. If unrecognized, if the tear is recognized intraoperatively, it should be sealed with a fibrin sealant. An unrepaired dural tear may be the cause of a residual pain if an intradural herniation develops later, at a later stage. The missed fragment, an inadequate decompression with incomplete removal of the fragment is possible in the early phase of the learning curve of the procedure. In literature, huge central disc herniations and highly migrated disc herniations have high failure rates. The success of the procedure lies in the proper preoperative planning based on the MRI. Adequate decompression can be judged by the free pulsation of the dural sac and the nerve root, the correlation of the removed fragment with the size calculated on preoperative MRI, and free passage of the nerve hook into the epidural space. The postoperative dysesthesia, it is a complication that is distressing to both the patient and the surgeon. The etiology is the excessive manipulation of the dorsal root ganglion of the exiting nerve root or the injury to the exiting nerve root. It is generally commonly seen with extraforaminal disc herniations. The trick to avoid this complication is the careful handling of the instruments, and proper needle targeting under C-arm is the key to avoid this complication. The residual pain. Persistent pain after surgery without a period of short-term relief is termed as a residual pain and is an indication of failure of the procedure. The most common cause is incomplete removal of the disc fragment, leading to persistent compression of the neural elements. Postoperative spondylodiscitis. This is one of the dreadful and uncommon complications with endoscopic discectomy. The diagnosis is suspected by severe back pain out of proportion to the physical signs and absence of radicular pain. MRI with gadolinium contrast is the gold standard for diagnosis. The infection may come from improperly sterilized instruments and endoscopic dyes, bacteremia from a urinary tract infection, or the intestine. In a complication like spondylodiscitis, the patient may require multiple endoscopic wash and debridement, and the samples to be sent for cultures and for treatment with further IV antibiotics. And if the infection is fulminant with osteolysis, bone erosion, and all, the patient may require autologous bone grafting and posterior stabilization also. Recurrence of disc herniation. Recurrence of herniation is defined by the reappearance of radicular pain after an initial symptom-free period. This period may be in weeks or in months. The recurrent herniation may occur at the same level and at the same side or on the contralateral side. The recurrence rate with endoscopic discectomy is similar to the gold standard microdiscectomy. A repeat endoscopic surgery is equally effective for recurrent disc herniations. What are the limitations of endoscopic spine surgery? The learning curve is substantial. The cost of the instrumentation is significant. The radiation exposure associated with the transforaminal procedures is more than other minimal invasive techniques. It should be remembered that conventional microdiscectomy or interlaminar endoscopic discectomy may be a more favorable options in some cases, such as highly down-migrated disc herniation at alpha S1, calcified disc herniations, and associated central stenosis. What are the complications and limitations of percutaneous instrumentation? The first, the increased radiation exposure, difficulty with long segment constructs. In a single level, it's easier for the rod insertion, but in multi-level surgeries, the insertion of the rods and the bone grafting is a challenging procedure. Biomechanical restoration, and this includes difficulty with revision procedures like difficulty with the use of instruments and difficulty at junctions level, such as cervicothoracic and lumbosacral junctions. Conclusion of this article, the concept of transforaminal endoscopic procedure is targeted fragmentectomy with minimal disruption of normal anatomy. The technical advances have broadened the indications of the procedure and have also improved its efficacy. However, with increasing applications, the risk of unexpected adverse events increases. Hence, diligent handling of the instrument with insight into the potential complications is necessary to improve the outcome. What are the flaws of this article? It is a traditional review and not a systemic review or a meta-analysis. Nowadays, all the reviews should be systemic reviews according to the PRISMA guidelines. Traditional reviews provide a broad overview of a research topic with no clear methodological approach. Information is collected and interpreted unsystematically with subjective summaries of the findings. Authors aim to describe and discuss the literature from a contextual or a theoretical point of view. Although the reviews may be conducted by topic experts due to preconceived ideas or conclusions, they can be subject to bias. In systemic reviews are the overviews of the literature undertaken by identifying, critically appraising, and synthesizing results of primary research studies using an explicit methodological approaches. They aim to summarize the best available evidence on a particular research topic. What are traditional reviews? The author is one or more authors, usually experts in the topic of interest. Study protocol, there is no study protocol. The research question is brought to a specific question and hypothesis has not been stated. Search strategy, no detailed search strategy. Search is probably conducted using keywords. Sources of literature, not usually stated and non-existent. Usually well-known articles prone to publication bias. Selection criteria, there is no specific selection criteria and usually subjective, prone to selection bias. Conclusion, sometimes evidence-based but cannot be influenced by author's personal belief. The results cannot be reproduced and it cannot be continuously updated. What a systematic review. Authors, two or more authors are involved in good quality systematic review may compromise experts in different stages of the review. Study protocol, there's a written study protocol which includes details of the methods to be used. The research question, there's a specific question which have all or some of the PICO components. The PICO stands for population, intervention, comparator, and outcomes, and space components, and hypothesis has been clearly stated. The search strategy, there is a detailed and a comprehensive search strategy is developed. Sources of literature, the list of databases, websites, and other sources of included studies are listed. Both published and unpublished literatures are considered. Selection criteria, there is a specific inclusion and exclusion criteria. Critical appraisal, there is rigorous appraisal of study quality. Conclusions drawn are evidence-based, and the updates can be periodically updated to include the new evidences. These are the PRISMA guidelines that should be ideally followed. PRISMA stands for Preferred Reporting Items for Systematic Review and Meta-Analysis. The identification, the number of records identified through database searching or number of additional records identified through other sources. They are screened up. The number of records after duplicates are removed. Then the number of records screened are for eligibility criteria, the inclusion and exclusion criteria, the number of full text articles assessed for eligibility, and number of full text articles included with reasons, and included articles and number of studies included in qualitative synthesis, and number of studies included in quantitative synthesis that can be included for meta-analysis. Thank you.